I would like to start saying that when I received the invitation to talk about fibromyalgia, chronic fatigue syndrome, post-viral conditions, I almost said no. I said, Elizabeth, why you gave me the most difficult topics? But I accepted the challenge because I said I need to learn. And I'm coming to this event today not as the expert. I think I'm here also as a learner. There are so much things to learn about these conditions. I don't pretend I know everything. And to tell you the truth, the more I study, the more I realize I don't know these conditions. The more confused I get. So I'm sorry if I'm not bringing clarity to you all today. If you expected me to come here and have the solutions for these three things, I'm sorry, this is not what's going to happen. I'm also confused. But as a pain expert, I work in Toronto. I only do this. I only see people who have pain, like Elizabeth also. I am a physician, so I do need to study and I do need to have answers for my patients. And sometimes it's hard to say, I don't know. You need to be humble to say, sorry, I don't know the answer. I don't know what to do. I don't even know what to recommend to you. So what I will show to you today is basically, it's the best guess of what I know about these conditions, including fibromyalgia, which I know for 30 years. Even before I came to Canada, I came to Canada 25 years ago, and 30 years ago, I graduated from medical school. And what brought me to the pain medicine, when people ask me, why did I decide to become a pain physician, was because of a case of fibromyalgia. So here it is. I hope at the end of this presentation, you'll be able to describe how these conditions are diagnosed in clinical practice, to list at least 3 strategies to help people manage their symptoms, and to discuss possible explanations for their pathophysiology. For those of you who are not clinicians, pathophysiology is a long word just to say the causes of these diseases. What are the mechanisms that cause these problems? In terms of conflict of interest, I do have a YouTube channel and I'll be mentioning some of my videos, and I do sign a YouTube partner program. So I end up getting some pennies in my bank if you watch those ads that are played during my videos, but you can skip those ads. I also have a book for people with chronic pain, and I do get royalties from the sales. And I have grants from 𝐒𝐂𝐑𝐈𝐁𝐄, Ontario Ministry of Health, Health Canada, Certas Insurance, WSIB, which is the Workers' Compensation of Ontario, and the Canadian Generics Product Association. Okay. So when we talk about these less understood chronic pain conditions, and Elizabeth gave me those topics, I would like to add other topics. Why only fibromyalgia, chronic fatigue syndrome, and post-viral? But I think this concept, what I'm going to say here, applies to irritable bowel syndrome, IBS, painful bladder, painful prostate, complex regional pain syndrome, tension headache. And the 2 conditions that are added, chronic fatigue syndrome, post-viral conditions, I put them separately here in small, just because the pain is less of an issue in this chronic fatigue syndrome and post-viral conditions. Although they have pain, we're going to see that. Pain is not the main symptom. It's fatigue that is the main symptom in chronic fatigue syndrome and post-viral conditions. So which mechanisms are involved in the pathophysiology? That's that word again, pathophysiology, the cause, the mechanisms of this condition. So if I ask you, I'm not going to, but if you could type in the chat the letters that you think are involved in the causes, mechanisms, pathophysiology of fibromyalgia, chronic fatigue syndrome, post-viral, and all of the other chronic pain conditions that I mentioned, which letters do you think would be involved? Is it genetics? Peripheral neuropathy, like small fibers disease is an example. Peripheral sensitization, central sensitization. Is it neurogenic inflammation? It's different from, neurogenic inflammation is different from neuroinflammation. Neurogenic inflammation means that the nerves in the periphery, they are releasing substances that cause inflammation. Neuroinflammation is if you have inflammation in the central nerve system. Is it chronic inflammation, like inflammation in the blood? Chronic inflammation, an example would be osteoarthritis. Is it hormonal? Is it nutritional deficiencies? Is it the gut microbiome? Is it sleep disturbances? Or is it an autoimmune disease? Is this something psychiatric, like a personality trait? Are there psychological features that cause these conditions? Is it related to adverse childhood experiences? So I can tell you, it's all of those. That's what makes these conditions complicated. It doesn't matter what you study. So there are some scientists that they focus on one of those things and they say, I found what causes chronic fatigue syndrome because I found that blah, one of these letters is implicated, is abnormal. So this, if it's abnormal, if the gut microbiome is different in people with fibromyalgia, therefore, I found where we need to focus the treatment is in the gut microbiome. But that's because you are a scientist only looking in the gut microbiome. If you were a scientist looking at the central sensitization, you're going to find abnormal. So a scientist, depends on where they look, they will find abnormalities in, not abnormalities, but they will find associations. That's what the problem is. We don't know if those things cause those three conditions, or if they are associated with those conditions, or if they are consequences. Of course, adverse childhood experiences are not consequence of fibromyalgia or chronic fatigue syndrome or post-viral infections because they happened before. But we know that people with fibromyalgia, they are more associated with higher incidence of adverse childhood experiences. Why is that? So you see how complicated it is because these things are associated. Sometimes they don't mean they are caused by, but something may be predisposing, something may be happening, right? So I could find here tons and tons of references to back up all of those factors that cause these things. I am not going to bore you with many, many slides talking about, these associations. I'll just read some for you. So for example, this article published in 2020 by Sarzi, Puccini and colleagues, many factors contribute to the development of fibromyalgia in a unique manner. Genetic predisposition, personal experiences, emotional cognitive factors, the mind-body relationship, and a biopsychological ability to cope with stress. Okay, here comes another researcher, Greystone, and says there is a high prevalence of small fiber pathology in fibromyalgia. And then another one says central hyperexcitability might be present in several pediatric chronic pain conditions, not only adult, but pediatric. Logia, he does, he's looking at the glial, those are the cells inside of the brain, and they found that those glial cells are producing inflammation. So that's the theory for neuroinflammation. Another one, vitamin D deficiency, has been associated with fibromyalgia. Individuals with fibromyalgia experience lower sleep quality, sleep efficiency. Is that the problem of sleep? Women with fibromyalgia frequently report adverse childhood experiences and also self-sacrificial behaviors like self-silencing. I like this one. The last sentence here comes from the European guideline, published in 2017. And I love this one because they say we don't know anything. Current data do not enable identification of distinct factors in the etiology and pathophysiology of fibromyalgia syndrome. It can be associated with inflammatory rheumatic diseases, gene polymorphisms, lifestyle factors, for example, smoking, obesity, lack of physical activity, depressive disorders, as well as physical and sexual abuse in childhood and adulthood. And there are many overlaps of conditions. When we talk about, we're not talking about them, these three separately. Like there are lots and lots of papers showing that there are overlap, for example, between fibromyalgia and ME, which is the other name for chronic fatigue syndrome, myalgic encephalomyelitis. Another paper talking about there are similar mechanisms in the physiopathologies of irritable bowel syndrome, IBS, and fibromyalgia, where the immune system, especially the mast cells, along with their products, receptors, the inflammatory cells, with their intermediaries, hormones, and neurotransmitters such as serotonin, they act together pathologically. There are positive associations between fibromyalgia, severity of overactive bladder, and so on and on. So I could be talking here hours about these overlaps. So in Alberta, I was in Banff when Dr. Claudia Sommer, she is the past president of the International Association for the Study of Pain, ISP. She was a keynote speaker at the Canadian Pain Society in Banff. And these are pictures of her slides. And after her presentation, I came to her and said, Claudia, I'm going to give a talk in 3 weeks. Can I borrow some of your slides? She said, oh yeah, of course. And we were chatting a little bit about, because she presented, what is the pathophysiology? What is the cause? What is wrong? Where is the problem in the body that causes fibromyalgia? And at the end, she basically, this was the summary slide that I borrowed from her, and it's basically everywhere. So there is genetic predisposition, yes. And then there is adverse life events, yes. And then there is a pro-inflammatory, yes. And then there is lifestyle, yes. Vitamin D, yes. More epigenetics, yes. Damaged C fibers, yes. Ongoing activities of fibers, yes. And then they cause the cycle to go back and causing this problem. Okay, so what do we know about pain, right? What do we know about pain mechanisms? Let's just take a little bit of a side road here. Again, the International Association for the Study of Pain recently, this has happened in the last 5 years, came up with these 3 types of mechanisms that cause pain. They are very distinct. And if a person has nociceptive pain, the treatments are very different if they have neuropathic pain or nociplastic pain. So what are those 3 types of pain? Because if we understand the mechanism of pain, which is, we're talking here, this is a Pain Society of Alberta, we're talking about pain, all of these conditions, although chronic fatigue syndrome does not have, not everybody has pain, not everybody has a severe pain, but it comes with pain. What kind of pain are we talking about? When we talk about fibromyalgia, chronic fatigue syndrome, post-viral infections, are we talking about nociceptive, neuropathic, nociplastic? Do we know? Okay, so let's see. And I have a video that I explain the 3 types of pain. This is a QR code if you want to watch that video. But I'm not going to show you the video today. I'm going to talk about the 3 types of pain can be this is how I explain the 3 types of pain. That video can be compared to an alarm system. And I think if people understand the function of an alarm system, it becomes easier to understand how we treat those kind of pains. So when you install an alarm system in your house, you have, sensors for smoke detectors, fire, burglar, water leak in your basement. Those sensors are similar to the sensors that we have for pain, and also sensors that we have around our body for danger. So if you think that the alarm system is detecting danger of your house, think about that as your body has a danger detector system. That fatigue can be a sign that you are in danger because you need to rest. Pain can be a sign that something is damaging, injuring your body. So think about that danger alarm that we have in our body. So you have the sensors, and then the sensors communicate with this box on the wall. This box on the wall, you can modulate, right? You can increase the volume of the noise that it's going to make. You can give passwords to different people to turn on and off. And this box on the wall communicates with the central office. Our danger system in our body is the same thing. We have those sensors in the tendons, bones, muscles, skin, everywhere. They send sensations, they send signals to the spinal cord or the brainstem, where they enter in the spinal cord, a lot of things can happen. You can give access to different people. You can modulate, you can increase or decrease the volume. Exactly the same thing. That box on the wall will send the message to the office. The office, in our case, is the brain. So once that information, that house is on fire, the office has to do something. Do I send the fire truck, the ambulance, the police? Do I send all of those? So our danger system in our body does the same thing. Once the brain receives that information, it has to decide, what do I do with that information? What am I supposed to do? Is the person supposed to rest? Is the person supposed to be quiet? Is the person supposed to go to emergency? You see, so when we have a injury, let's say an injury in the knee, okay, so the person damaged their knee, there is a torn ligament in the knee, they were playing soccer and they have a knee problem, that message is a sensation, will go where? To the brain. So the brain is the central office of this alarm system. It will sign the alarm, bling, 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 bling. You have to do something because you cannot live with that signal, that noise. In the case of fatigue, the signal is you are tired. It's not pain, but it's fatigue. You cannot get up. You have to lie down. Something is wrong with your body. You need to rest. In case of pain, maybe the signal says you have to go to emergency. Don't rest right now. You have to go to emergency. You have to talk to your doctor. You have to get another MRI. You have to get another blood test. You need to find out what's wrong. The brain will send messages to that knee saying, okay, you don't need to hurt anymore. Okay, I'm taking care of this. You already saw the orthopedic surgeon. They said this is a minor torn of the ligament. They are going to take care. Your pain can get down. You just need to take care. This is going to take a few weeks to heal, but it will heal. And you probably don't need to feel pain anymore. So that's the normal situation. And then it will send all these messages of healing. However, we know that this is normal in acute pain. In acute pain means, okay, there's a fire somewhere. Okay, fire in the kitchen. Let's call the fire truck. They come, they put up the fire. Now the kitchen is renovated. The kitchen is ready for you to use again. Why you're not using that body part? The virus from COVID or a flu, it's gone. It's not in your system anymore. The virus from COVID, we know it stays in our system just for a few days until your immune system gets up and defend yourself and kill all the virus. People who died of COVID, including my father-in-law, I lost my father-in-law to COVID. He died 6 weeks after he had the infection. It's not because the virus killed him, no. It was the reaction of his body. The virus was removed from his body a few days, but his reaction to the virus is what killed my father-in-law. So sometimes the reaction of a person to a virus is worse than the virus itself. Sometimes the reaction of a person to the acute pain is worse than the acute pain itself. So that's the transition from acute to chronic pain. The kitchen is renovated. Why you are not using the kitchen? Why you are still eating takeout food? Why you're going to restaurants? Look at your kitchen. But I'm afraid of using my kitchen. Afraid of what? I'm afraid that I'm going to cause fire again. I'm afraid every time I get into that kitchen, I get anxious. I remember the fire. So even everything is new and renovated, I can still smell the fire every time I go to that room. Because there is a strong, it's almost PTSD, post-traumatic stress disorder, that they have of the pain or the trauma, the virus or whatever started those symptoms, that those memories are still very vivid. And the brain is still living in that state of acute disease. So the person is not imagining this. I'm not saying that they're making this up. It's real, very real, but the acute injury has healed. So again, all of this, they have this in common, is this sensitization. It's this abnormal reaction to something that was acute, but now it's chronic and it's healed. So it's almost like the house, living in a house that the alarm is going off all the time. It's very loud because it's sensitized. The volume of pain is turned up. The pain or the fatigue is constant and it's very debilitating, but they go from doctor to doctor, and nobody can find what is wrong in the body because the body has already healed. So what do you need to do? You need to fix the alarm system. You don't call the ambulance, the fire truck, or the police. You call the alarm company and say, you know what, my alarm system in my house is making this noise, constant, very loud. Can you come here and regulate the alarm system? Oh, that's what we need to think about. So those three pains, remember the three types of pain: nociceptive, neuropathic, nociplastic. People from the smart people, smarter than me, I had nothing to do with this. I'm here just the messenger. They came up with these three mechanisms of pain because nociceptive pain means there's a fire. You have to put up the fire. So if your joint is inflamed, you have an inflammation here, you have to go there and treat the joint inflammation with anti-inflammatory, and that's nociceptive pain. If the wires that transmit this pain to my spinal cord, to my brain, are cut, or there's a short circuit, I have a neuropathic pain, could be multiple sclerosis, spinal cord injury, stroke, diabetes that cause peripheral neuropathy, herpes zoster, shingles, trigeminal neuralgia. Those are all examples of neuropathic pain. You treat differently. Now, nociplastic pain, which is the third mechanism, is when this alarm system is deregulated. So you need to fix the alarm system. So how do we diagnose fibromyalgia? Because fibromyalgia is what we think is a disease of this pain system. And because the pain system is everywhere, the pain system involves the nerves, the nociceptors, the immune system, the endocrine system, involves the emotional system. So it's the whole body system. How do we diagnose this? So we apply the 2016 diagnostic criteria, ask the person to say which areas you have to pain. So they need to have widespread pain. So we describe, these areas of the body. They have to have multiple areas. And then we also ask them about the severity of those symptoms. So they need to have not only pain in many parts of the body, but these symptoms need to be present: fatigue, trouble thinking, and they have to be severe, like waking up tired. And they also sometimes come with mood disorders, anxiety and depression, and headache. So we apply this criteria and say, okay, yeah, you do have fibromyalgia. What is another criteria that we use, and I'm using this now in my clinic, all of my patients now complete the central sensitization inventory, which is a CSI for short. It's a questionnaire that we ask them, and we then give points, 100 points maximum. And if a person scores more than 40 in this questionnaire, we know that they have sensitization. What is central sensitization? Is this phenomenon by which the neurons, especially the pain transmitting neurons, are hyperexcitable, resulting in this hyperexcitability. So they respond faster, and the volume is turned up, not only for painful stimulus, but also for non-painful. That's why they also have hypersensitivity to noise, light, smells, chemicals, because they are sensitive to not only pain and tiredness. Tiredness is normal. Everybody feels tired. If you exert yourself, you feel tired, but you rest, and the next day you are okay. But excessive tiredness to the point that not even resting can, recover, and it's extremely exaggerated, that's what chronic fatigue syndrome is. And pain that is exaggerated because they are feeling more pain. Their volume is up because of this sensitivity. So we have ways of measuring this. And I do have another video that I explain central sensitization on my channel and how to desensitize the brain. I like this report. It's from the Institute of Medicine, published, I didn't put the date here, but this was published a couple of years ago, where they say, redefining an illness. Because again, a lot of people who have this exaggerated pain, exaggerated fatigue. They're labeled as lazy, malingering, they don't want to work, they don't want to do anything. These are, the stigma is horrible, and it only makes the person even worse, because now if they feel they are stigmatized, not believed, and the system doesn't support them, guess what? Now they will be more depressed, more anxious, more, the trust in the system will be lost. And now they have more issues than they had initially, because they have all of these emotional issues on the top of their disease. So the first thing is, it's serious, it's real symptoms, all of them, post-fatigue, chronic fatigue syndrome, fibromyalgia, post-viral, and all the other ones that I mentioned. They are serious diseases. They are real diseases. They're not inventing. But for the medical system that is used to treat people with acute diseases, they don't understand what's going on, because I tested you, I examined you, and you're all normal. So unfortunately, chronic fatigue syndrome affects many people. And until we find exactly what is causing and how we can treat, is going to be challenging because of this skepticism in the healthcare system. And again, I have a video on my channel that I did many years ago. And I did this video to explain, because even though my channel is for people with chronic pain, many of my patients do have chronic fatigue syndrome overlapped with chronic pain. And what are the pillars of myalgic encephalomyelitis and chronic fatigue syndrome? It's just two names for the same thing. I like this paper by Rivera. It's almost like a compendium of a summary of all the evidence that we know about chronic fatigue syndrome. If you want to read one paper, read this paper by Rivera. So they talk about, the pillars are, the condition is affecting the neurons and the cells in the central nervous system. The immune system is also affected, and the endocrine system, which is very similar to chronic pain. Chronic pain, fibromyalgia, complex regional pain syndrome, they all overlap. All of these systems, they overlap. What are the clinical manifestations of chronic fatigue syndrome? Fatigue is the main one. So it's a fatigue that is deep fatigue, extremely intense, doesn't get better with rest. And they have fatigue with minimal activity, sometimes brushing their teeth. They have this post-exertional fatigue, which is they have to rest for 24 hours because that was enough. So it's it's that sensitization, is that their body is exaggerating because there's a strong response. They also have sleep dysfunction. They may not have, but it's not uncommon to have pain. And the pain is muscle pain, joint pain, or they may have overlapping with fibromyalgia. Chronic cognitive dysfunction, headaches, and that post-exertional malaise. And they may have autonomic, neuroendocrine, or immune dysfunction as well. How do we treat pharmacologically? We don't have one pill. We don't have one treatment for chronic fatigue syndrome, unfortunately. So we treat the symptoms. If we know they are, the best thing, I would say the best treatment would be prevention. So I am a big proponent of vaccines, because vaccines prevent people from getting viral infections. I got shingles a couple of years ago, and I said, oh my God, what if I have, postherpetic neuralgia now? Immediately, and I had not had shingles vaccine. And then I said, now I had to wait 6 months. And after 6 months, I went and had my shingles vaccine. I was the first one in line when they approved the COVID-19 vaccine. I was the first one. I said, I want to have my vaccine, because I was not afraid of the virus itself, although yes, but I was more afraid of the consequences of viral infections. So I would say the best prevention for viral infection post symptoms after infection is not to get viral infection. However, for chronic fatigue syndrome and for fibromyalgia, I don't know how to prevent those things. I actually don't know if we can do anything to prevent. Maybe exercising well, sleeping well, eating well. Maybe those things will prevent people from developing chronic fatigue syndrome and fibromyalgia? Maybe, but I don't know. I'm just, I'm very ignorant here. But when a person develops chronic fatigue syndrome or post-viral, then we treat them with what we know, like if they have headaches, muscle pains, maybe we give them NSAIDs, sleep problems, tricyclic antidepressants, SSRIs, antiviral if they are having viral infection acutely, monoclonal antibodies. I never had to do that because I don't see them acutely, I see them more chronically. Complementary alternative medicines and corticosteroids. I never gave corticosteroids to people with chronic fatigue syndrome and post-viral, but I do give corticosteroids for people who have complex regional pain syndrome, especially if they are in the acute phases. Now, let me tell you this. I came across Raylan Agley a couple of months ago. I never met her in person. I met her via YouTube. She has a YouTube channel, and I started watching her videos. She claimed that she got cured from chronic fatigue syndrome. And I said, okay, what do you mean by being cured of chronic fatigue syndrome? Because I know some people after, 2 years, 3 years, 5 years, their symptoms start getting better. And now they don't have the symptoms anymore, but that's the natural history of chronic fatigue syndrome for a lot of people. And then I started watching her channel. And because she started telling her story, now she has a wait list of people waiting to be interviewed by her on her channel. They all heard her story, and they are also cured from their chronic fatigue syndrome. So a couple of months ago, I contacted Raylan and I said, Raylan, can I talk to you? Because what did you do? Am I doing something wrong? What should I tell my patients? And actually, I'm glad to say that I just released this video that I interviewed her on my channel last week. So if you want to watch, but her history is interesting because now she's 45 years of age. She's fully recovered, but I'll tell you what she told me in the video, and you can watch the video or you can go to her channel. At age 30, she was a full-time social worker, very athletic, going to the gym, running. She was a runner, gym, loving going to the gym. She was very stressed out, and she got a viral infection, and boom, immediately she felt severe fatigue, and she could not get up. She never had pain. She told me she never had pain, maybe a headache here and there, but pain was not a big issue for her. But she was unable to get out of bed for 2 years. She had to go on long-term. She lives in the United States. She's Canadian, but she lives in the United States. She had to go on long-term disability. Her doctor had difficulty to complete her forms because the doctor told her, I don't know what to write in the form because I can't find anything wrong with you, just that you're telling me that you are tired. She had multiple investigations, treatment, and she said that there were months that she was spending $1,000. Her boyfriend, now her husband, was paying these treatments for her, and she was spending $1,000 a month on vitamins, supplements, and treatments, everything that was being done to her. And then she said she changed her lifestyle and recovery was gradual. She started taking charge of, she said, I don't need help from anyone else. She stopped taking all of those supplements and going to people. And she said, it's not working because I've been on this for many years. I need to change my approach. So she started looking inside of her, asking, what can I change in my life? Because what everybody's doing to me is not actually working. She started with sleep, nutrition, just eating healthy, less stress, gradual movement, brain retraining, journaling her symptoms, and she was fully recovered at age 40. And then she opened her YouTube channel. She's now 45. She got a full-time job now. She works out 6 days a week. She runs a busy YouTube channel. She wrote a book, published a book, and she writes newsletters, so she's very active. So in summary, how do we diagnose all of those things? And I think they all are synthesized in a sensitivity syndrome that could be involving all of those symptoms, including the guts, because the guts are affected in people with fibromyalgia, but that's because it's part of the immune system. So we take a pain history, a medical history, an emotional history, and then you diagnose this sensitivity syndrome. And I like to summarize things that, how do you manage? So lifestyle modification, and there are some things we could try, but where do we have a lot of evidence to help all of the syndromes that I mentioned before is in the mind and movement. The other ones, modalities, there's not a lot of evidence. Manual therapies, they're good, nice, but there's not a lot of evidence that people should be doing this for the rest of their lives. Like, they're very expensive. And medications, unfortunately, we don't have one medication that would do what Raylan did with her life just by using, basically what Raylan used is what is in the first two boxes, and changing her sleep and nutrition. So in terms of mind-body strategies, I'm not a psychologist. I will leave this for Elizabeth if she wants to answer any questions about this. But this is what we are using now in our hospital here at 𝐒𝐂𝐁 in Toronto. When we decide to tell our patients to start doing those lifestyle changes, we use a stepped approach. First is communicating the diagnosis. This is what you have. It's a real diagnosis. Did you consider self-management? We provide education. We ask them to start journaling their symptoms, journaling their therapeutic. It's more not journaling their pain and fatigue, but journaling what they're feeling, their emotions, what is working for them. And there is a technique that people do this. If symptoms persist after we do these initial steps, then they can be recommended to go to PRT, pain reprocessing therapy, if most of their symptoms are more in the fear, lack of focus, they're fighting, frustration, figuring out and trying to fix the problem. I don't know don't ask me questions about EAET. I hope someone here understands, but our psychologists and psychiatrists in our team, they recommend, if the person suffers from trauma and anxiety, they recommend EAET. And the other one that I also don't know much about it, but we are recommending is the ISTGP if the person has maladaptive avoidance and anxiety. In terms of fibromyalgia, I have many videos about this, and what I recommend to my patients is also a gradual increase of physical activity. Think about 3 types of exercises and start low, go slow, and I have demonstrations of this for strengthening, aerobics, and stretching exercises. There is evidence that these 3 types of exercise help people with fibromyalgia. So that's the end of my presentation. So I hope you remember what we were supposed to discuss here, that I wanted you to understand these conditions and how we diagnose them in clinical practice, at least 3 strategies to help manage those symptoms, and some possible explanations for what is causing those problems. Thank you very much. This is where you can find me. It's Elizabeth. I'll send back to you.
Thanks so much. So we did have a few questions, and I think we only have time for a couple of quick questions. And I think a lot of them have to do with any good education session often creates more questions than it does give answers. So one of the questions we had is, how do you tell if something per se helped to treat one of these conditions such as CF or fibromyalgia versus it just going away on its own? How do you know the difference?
Yeah. So in clinical practice, it's really hard to know that, because we do give question in my clinic. Every visit, the patients complete the brief pain inventory, and we do look at them and we do compare this with the previous visit and with the previous visits. So brief pain inventory has 3 components. It's the pain diagram. So we look at the areas that have pain and symptoms, and then they have the pain scores, and then how those pain interferes with a number of activities of daily living. And we look at those scores and we say, oh, you see your sleep is getting better. So we compare the person, them today, with themselves in the previous visit. So we know, but I have no idea to know if this is natural history of the disease or if this is because of the treatment that I gave to them. Now, in clinical trials, that's why it's so important in research, in clinical trials, always to have a control group, because a control group that you don't give the intervention, you will know that they got a little bit better or not better or worse, And now you know that what you gave made a big difference.
Well, and I think too, the other piece of that is maybe it's okay that you don't find one thing that made all the difference. If you make a lot of these positive changes, they could impact functioning in a lot of different ways. And I think we're a society that wants one thing that just, that's the answer that solves the whole problem.
Yeah.
Maybe it's okay for it to not just be one thing.
Yes, doesn't need to be one thing. And we look at, in general, we also don't look at only one response in the scale. We look at them, how everything is moving towards the goal that we want. And sometimes the patient made a lot of changes in their life between these visits, and I don't know which one was responsible, but it's okay, you know, as long as those changes are healthy. And I always tend to look at how much money you are spending, or how much, you know, interventions you are getting done to you. My philosophy is things that are not expensive, less expensive interventions, and things that you can do for yourself instead of people, you become dependent on someone that you have to go there every week for them to do for you. So as long as the whatever they're doing is more self-management, they're changing their lifestyle to something healthier, I'm okay. Keep doing what you're doing because you're going the right direction.
The other question we had, and this is going to be the last one for today, is around some of the comorbidities. So how can you manage it if you feel like there might be some comorbidities that are co-occurring that could also be contributing to fatigue? So how do you differentiate that, knowing that potentially it could change the treatment plan?
Yes, of course. I think I'm a physician, so I feel a responsibility that I am excluding any comorbidity that could be treated. So I'm always paranoid. Am I missing a comorbidity that I could be treating? For example, thyroid problem, because thyroid problems, if the person is hypothyroid, they may feel fatigued all the time and even pain. So I don't want to miss that because it would be a huge problem, you know, for me and for the patient, and I don't want to. So I'm always paranoid. And once I checked, you know, this is not diabetes, it's not a kidney failure, it's not a liver problem, it's not a thyroid problem, and there could be a lot of other things. But you only need to do like I do some blood exams, and you treat those things. Of course, a person with thyroid problem, you treat the thyroid, they improve the symptoms. If they don't improve the symptoms, but you know the thyroid is now normal and they still have the symptoms, now you can say, well, I think you have on the top of the hypothyroidism, you may also have fibromyalgia or chronic fatigue syndrome. So it's really important that we think about all of those possibilities and we are treating the other ones.
Absolutely. Thank you so much, Dr. Furlan. For everyone, if someone can please put the link to Dr. Furlan's YouTube channel, Instagram in the chat, that would be amazing. I know a lot of people are dying to get more information. Thank you.